Hello everyone, my name is Mario Martinez, and I'm one of the instructors at Texas EMS Academy. Today we're going to be going over what you should expect for your first couple EMT basic rideouts, or clinicals. We're also going to be going over a couple tips that you can utilize whenever you're on the medic unit, as well as a medical scenario that we're going to be simulating together. We're going to be doing so in the eyes of an EMT basic student, so that way you'll be able to see the perspective of you going into a medical call, potentially for the first time, seeing some of the expectations and some of the skill sets that you may have to utilize, as well as some important questions that you can ask. As a student, we want you to participate as much as you possibly can. This means trying to get you involved as much as possible, such as obtaining vital signs. Maybe we want to establish an airway device for our patient, such as a nasal cannula, a non-rebreather, a bag valve mask, or a nebulizer, just depending on the scenario. You may need to consider using either your EMT basic medications or your AEMT medications, depending on the course that you're taking. If you forgot how to utilize some of your medications, that's okay. We're going to work with you while we're on a call. From setting up either the airway device or the medications that you may have to administer, all the way up to the actual administration of the medication, or again, the airway device. We don't expect you to be a pro. You are doing a rideout or a clinical, so this may actually be your first time doing so. That's okay. We really just want you to get involved with the scenario. Also, try to remember your mnemonics, such as sample and OPQRST. You're going to find that asking questions to real-life patients may be more difficult than you initially realize. So remember, we have signs and symptoms, allergies, medications, past medical history, last oral intake, and events. If your patient is in any type of trauma or any type of pain, we can also ask onset, provocation, quality, radiation, severity, and time. Now, everything that can go wrong during these rideouts is probably going to go wrong. That's okay. We expect that. For instance, you may be trying to put a blood pressure cuff on a patient and you realize that as you're establishing it, it may slide off a lot, or it's a lot harder to do compared to establishing it on one of your peers. Another skill that may surprise you is while you're setting up a nasal cannula for the first time, you may accidentally start choking your patient like I did whenever I was an EMT basic rideout. That's okay. It would be really odd if during your first couple clinicals, you're already a pro. While you're doing your rideouts and your clinicals, we expect you to pretty much mess up on everything, at least for your first time. But what we do expect is for you to actively participate and try your best. During your clinicals, you'll be working as a team, and it's good if you mess up whenever you're riding out with someone such as myself, compared to if you're riding out by yourself. If you think about it, every mistake that you do on the field may be a reminder that'll help you later on during your EMS career. For instance, again, you may falter whenever it comes to establishing vital signs on your patient, at least for your first couple times. That's okay, because you're going to remember, hey, I was riding with Mario or another individual, and I remember struggling on that skill in the field. Now I've gone back and practiced it, and now that I'm alone in the field or with a partner, which may be an EMT basic or an EMR, depending on where you're working at, I'm able to successfully deploy that skill and utilize it to better help with my patient care. When you make a mistake on the field, don't feel embarrassed. Feel excited that you participated and that you actively made that mistake. At the department that I currently work at, I've never seen anybody actively make fun of each other after making a mistake on this field. All we want to see you do is actively participate during the calls. And go ahead and make those mistakes with us. Also, be honest with yourself. We understand that you're only on an ambulance for 8 hours at a time during your clinicals or your rideouts. You're not going to memorize every single compartment and every single piece of equipment that's on the box every time. But we would like you to have a general idea of where the different compartments are at whenever you're doing your clinicals. Whenever you're doing your clinicals or your rideouts, don't be afraid to ask questions. Just try to be the best student that you can be. Now with that being said, let's go ahead and take a look at the box together. Alright everybody, so here's Medic 72. As you can see here, this is where we put the backboards at. If you need to access them, they're going to be in the back side compartment. And they're going to be on the outside. Over here we have our jump bag. This is where we keep some of our main equipment. So we'll have like our BVM, some LMAs in there. We'll have IV equipment. We'll have some of our airway equipment, our IO kit, things like that. Over here we have the trauma bag and we have the medication bag. Here's where we keep our IV equipment. So you can see here we have some of our IV catheters, our saline flushes, things like that. Our monitors over here as well. We have our airway cabinet, which has things such as like our nasal cannulas, our non-rebreathers, our BVMs, our back valve mask, our nebulizers, CPAP equipment, endotracheal tubes, things that you really won't have to worry about depending on your level of skill. We have our trauma cabinet over here, which has like our OB equipment. We have our hot and cold packs. We have our protocol book in there. Some of our splinting equipment, our 2x2 gauzes, our 4x4 gauzes. If we look over here, we have our tourniquet that's kind of tucked away, but if you zoom in, you can kind of take a look at it. We really want to know where our tourniquet is at, since that's one of our more critical pieces of equipment. We have our miscellaneous cabinet, which also contains some like stretcher sheets. It has our lidocaine drip, our levofed drip, and our TXA equipment, as well as just some extra gloves. In this cabinet here, we have our saline bags in case we need to spike a bag. So everyone, if you want to be successful in your rideouts, you really want to make sure that you take out the stretcher. It's always a good idea to do this kind of practice. Don't be afraid to go out with the crew, ask them, hey, I've never seen the stretcher before, can you help me pull it out? They're going to respect you whenever you see that, they'll work with you on it. And if you can pull out the stretcher with the other crew members, you'll already make yourself a huge asset to this team. So you can see here, I'm pulling out the stretcher right now. We have a system where we have to release the wheels at separate times. Plus is to play, minus is to put away is generally the rule of thumb whenever you're dealing with any type of stretcher. And as you can see, I'm going from a unload position to a load position. That's where it raises past a certain elevation. So I can hook up the stretcher back into the medic unit with the safety latch. And I'm just going to raise up the wheels one by one, and it's a really great stretcher because this way I don't have to potentially put my back in any type of danger. So if you're not familiar with the stretcher, maybe you need to pull it out more than once. Maybe you need to ask the crew, hey, I'm going to go back downstairs and work on it by myself. You know, show that you're trying to familiarize yourself with this equipment that's foreign to you. So we just got dispatched to a respiratory call. As a student, you should think, okay, I'm on my way to my call, I'm sitting down, we're riding out to it, and it's going to take about approximately 5 minutes or so to get on scene. What are some things that I need to know? Okay, well, if I'm being dispatched to a respiratory call, and I heard it over the intercoms for the dispatch, I might want to turn around to the lead medic over here, where their window's at, and say, hey, what does it say on your MDT? What kind of notes do you guys have? As I'm sitting up there as a lead medic, I can say, okay, this guy really wants to participate. He knows that we get dispatch notes, and he's asking questions about it. And then I can say something like, okay, you have a 30-year-old male who was working outside when he started to feel short of breath, and he went back inside and called 911. Okay, just gathering that, I can think, okay, well, what might have happened? Why did he get shortness of breath outside, right? Maybe it's a cardiac call. And it's not actually a respiratory call, but that's just the dispatch notes that we have. I might want to know some things in my medication bag. I might have to assist him whenever it comes to breathing. In regards to maybe I need to know where my nasal cannula is, right? So I can look over at the airway cabinet, and so I can say, okay, I'm not on this box too often, but I have the time to look at the box while I'm riding out to a call. So the box is shaking right now. I'm acting as you, the student, riding out to my first call or first couple calls. And I've only been on this box for a couple hours. So it's okay if I don't know where everything's at. I can look back here and say, okay, where's my nasal cannula? It's right up here. Okay, where's my non-rebreather? Non-rebreather, it's right here. My nebulizer, I'm gonna put hands on it. I'm gonna say, okay, my nebulizer for an adult patient, it's right here. My bag valve mask, where's it at? It's right here. That way, if I show up on scene and we bring in a patient, we're like, you know what? Student, go ahead and set him up on a nasal cannula. And I see you reach over here and pull out a nasal cannula without me having to say anything else, like pointing out where it's at. I can say, wow, this student's prepared. He checked off his box and he really knows what he's doing. And realistically, you're not going to remember it all throughout the day or all throughout the clinical as you initially check off your box. That's okay. When we're heading to a call and you know it's a respiratory call, look at your box, figure out where things are at. So, okay, I know where my nasal cannula is. Another big thing, okay, if it's a traffic accident, I might need to know where my traffic vest is. I can see very clearly that it's right here, but if you're kind of in a daze, I also have another one right there. You can say, I know we're going to a traffic accident. I know I'm gonna need a vest. Where are they at? Do they keep them anywhere here? Oh, it's right there. Oh, it's right there. Fantastic. Let's go ahead and throw that on before I get on the call, so I can just pull it out. Oh, it's kind of stuck here. Hey, we'll grab the other one. This is the one I would have grabbed anyway. We'll kind of pull it out from here. And we will throw on a traffic vest before we get off the box. That way we're staying safe, and at the same time we're showing that we're prepared for the call. We're ready to help. We're not going to be a liability. Instead, we're going to be an asset to the team. One really big thing that I would recommend to students is while we're heading to a call, make sure to put on your gloves, right? So I'm going to reach over here. The box is shaking, so be careful. Now grab a set of gloves. Your hands may be wet from being sweaty. That's okay. Go ahead and dry them off on your pants. It's okay to be nervous for your first couple calls. And go ahead and throw on a pair of gloves. Let's see. There we go. You don't want to be caught as the medic unit arrives on scene and they're pulling out the monitor without gloves on your hands. What if your patient's right outside? What if they stumble inside and they have cuts, bruises, they're potentially bleeding, they have bodily fluids on them? You can't even reach out to help your patient because you haven't put on your gloves yet. So throw them on before we get on scene. Another big thing that we talked about earlier is we're headed to a respiratory call. So let's go ahead and look at some of our respiratory medications. So I know that this is the medication bag. I know that potentially I'm going to have to use one of these medications. So we're riding to the call. We still have a couple minutes. I may need a quick refresher before I get on scene since I'm a student and I'm not normally on this box. Where is my albuterol? Where is my aspirin if it's a chest pain call? Where is my epinephrine? So if I open up here, here's my aspirin right here. Okay, now I know where it's at. Here is my nitro in case I need to administer that medication. If I look here, for Medic 72, we carry adrenaline instead of an epinephrine auto-injector. That means that if I have to administer epinephrine to a anaphylactic patient, we're going to have to drop the medication versus the epi auto-injector. Now we're going to simulate using an epi auto-injector later on, if that's what the call calls for. But it's good that you note the differences between the drugs that we talk about in class versus the drugs you're actually going to use. Talk to your lead medic. They'll be glad to explain to you the difference. If there really even is any. It's just really more so how it's dispensed. So, close that up. Adrenaline is just another name for epinephrine. Here is my albuterol. So if I need to set up a nebulizer treatment, what do I set a nebulizer at? At 6 to 8 liters per minute. At Annaville, something very special, we administer 2 rounds of albuterol, or 5 milligrams per 6 mLs, in a nebulizer for a treatment for a patient that's having an asthma attack. So it's just something to note. Let's say I'm headed to a trauma call. Am I going to want to know where the 2x2 gauze is or the 4x4 gauze is? Yeah, sure, that's nice to know. But it's not something critical that we need to know of right away. What is something critical that's in the trauma cabinet? Well, if I'm heading to a trauma call, I want to know where my tourniquet is, right? I'm not going to fault you if you take a minute or so trying to find our 4x4 gauze. But if I have an arterial bleed for a patient and we're not able to control it by pressure with gauze, I might have a minute to a minute and a half whenever I get on scene to where I need to apply tourniquet before my patient bleeds out. So knowing where this is extremely important. Knowing where a 2x2 gauze is or a triangular bandage, well, that can probably wait a little bit, right? So don't stress out too much on knowing where those are. Just know where the general trauma cabinet is, respiratory cabinet is, or whatever equipment or medic unit you're on. But knowing placement of things like a tourniquet, like a bag valve mask, that's huge. That's something that you're definitely going to want to pay attention to. One other thing I'd highly recommend before you get on scene, let's go ahead and take a look at the monitor together, because this monitor may be different from your classroom, or they may compartmentalize things differently than what you're used to. So I need to know where my on button is. I need to know what button I need to press to cycle a blood pressure. I need to find out where my blood pressure cuff is at, so I have the cuffs out here. You can see I have my pulse ox, or my SpO2-ometer, right here. I have my 4 lead and 12 lead in here. If I open up this compartment, I have my thermometer. And I have my AED adults and pediatric pads right here. Where's my glucometer? Well, it's on the side of the monitor. To further help them, I may want to disconnect the monitor from where it's charging at. I may want to pop this and kind of struggle a little bit. The trick for these type of swivel and releases is you press it and then you kind of scoot it from the back, pressure from underneath here, and then it should pop out like so. But having that preset, so whenever we get on scene, if they need to utilize the monitor, I have it ready to go and I can pull it out with my gloves on so I can be a huge asset to the team. Hello, fire department. Hello, fire department. Fire department. Hello. Fire department. While walking up to my patient, I can get a general overview of the scene that's at display right now. I can tell how my patient is doing simply by him responding to me. This gives me a way to assess his mental status, where I can see if he's alert, verbal, and then if necessary, I can check if he's painfully responsive or unresponsive. I'm checking to see if he's able to properly respond to my commands. Also, you can notice that my patient's sitting on the floor as I'm walking up to him. What could have possibly happened? We know that this is a respiratory call. If we're considering something such as anaphylaxis, we may need to be on the lookout like, hey, is there a possibility that it was caused by bees? If that's the case, all right, are they in the general vicinity? Okay, we're inside of an enclosed area. That generally means that we're gonna be safe. Maybe he ran over here and is sitting down right now trying to catch his breath. You always wanna reassess the scene and check for scene safety. So that's a really big thing. You also wanna make your presence clear and show that you're ready to help the patient. Hello, sir, what seems to be going on today? Also, student, while I'm asking him questions, go ahead and start setting up baseline vitals on my patient. Okay, sir, so what's going on today? Oh, well, I was outside working in the yard whenever I suddenly got stung by bees. Okay, sir, I can see you've got some hives that are present on your face as well as your chest. Let's go ahead and make sure that we get the pulse ox set up first. I can see you're already doing so. That way we can narrow down how his room SpO2 is, and if I need to administer a quick airway device on the patient. Notice how, as I'm working down low with my patient, I'm not sitting down on the ground. You never want to get into the habit of working low with your patient where you're sitting on the ground. You're unable to move in case your patient suddenly vomits, in case the scene suddenly becomes unsafe, let's say the bees appear, or you may be leaning or sitting down in a puddle of urine, either if it's a patient's household where they have carpet and you're potentially sitting on, let's say, cat urine, or the patient might have had incontinence on himself. So get into the habit whenever you're getting down low to stay in a ready position such as this, where if I need to spring up, I can do so immediately. Just a little tip. So have you been stung by bees before? Yeah, I've been stung a couple of times in the past. It seems like it gets worse every single time, and I had a pretty severe reaction. Okay, sir, do you take any medication whenever that occurs? Yeah, I take my EpiPen, but I left it at home today, and I'm just having a lot of trouble breathing right now. I'm really concerned. Okay, well, I can see you have obvious hives. It looks like you're having a little bit of trouble breathing also. I like to preset my blood pressure cuff to about 20 units or 20 millimeters per mercury before I try to get my stethoscope placed, ready to go. That way, it keeps the blood pressure cuff from sliding around my patient, which you're gonna see is gonna happen a lot whenever you're setting this up on a live patient. Now, this isn't how you put on a stethoscope, but I'm just gonna do that so I can keep my audio piece in. But, of course, it would go in your ears. Student, after you set up your vital signs, let's go ahead and pull out the Epi auto injector. And at this time, I'm kind of visualizing more so where the hives are located at. I can see that there's some on his chest, some around his face. There's some obvious swelling. You can see some angioedema, which is facial swelling. While I can't really mimic it so much on a mannequin, you can maybe see that he's wheezing a little bit. He's having a bit of difficulty breathing. So we're definitely going to want to give him epinephrine soon. Okay, you would like the epinephrine auto injector? I agree. Let's go ahead and set that up. What we can also do while we're working on setting it up is we can listen to lung sounds. I can ask Rescue Randy over here to lean forward a little bit. He's so heavy. And I can listen to the backside of the lung sounds. And usually whenever a patient leans over a little bit, it's really easy to visualize or to hear the lung sounds. If I were to go down low, right here, if I was mimicking what I would do on the backside, I would listen to the right upper lobe, then go across, listen to the left upper lobe, then I would go to the right lower lobe, and then the left lower lobe. This is definitely a call where you'd want to listen to lung sounds. By doing so, you can tell the lead medic what's going on, and you can end up being a great asset to the team. So I love seeing students trying to listen to lung sounds. It shows that they're really paying attention in class, and they may catch something that I might not have noticed initially. Okay, so I have my epi auto injector. I'm going to remove the safety cap. This is just a training simulator, but I'm going to take an alcohol prep pad. If I had an opening, luckily he has a tear right here, clean around the area. If not, it's okay. But anyway, I'm going to take the epinephrine auto injector, go on the lateral aspect of the thigh here, and go ahead and inject. I'm going to wait approximately 10 seconds. Then I'm going to let go. This is now considered a sharp that has been deployed and can potentially stick you. You can see here that it went ahead and covered itself back up. Even though that's the case, I still want you to treat this as a sharp, like as you should. And if you have a sharps container somewhere, I want you to dispose of it properly, immediately. There's no reason why you should get stuck after giving someone an epinephrine auto injection. For this case, we're gonna put it right in here for right now, but we'll make a note of that later. Okay, Rescue Randy, now that we've given you the epinephrine and we waited approximately 1 to 2 minutes, how do you feel now? Oh, I feel so much better, like I can breathe again. Thank you guys so much. Well, sir, even though you feel like you can breathe better, I don't want the symptoms to pop up again whenever we leave. So I'd highly recommend going to the hospital. I think it'd be in your best interest. Would you be okay with us taking you to the hospital today? Yes, I think that's a great idea. All right, well, fantastic. Well, we're gonna have to visualize a different method than carrying this guy because he is heavy. So we're gonna do a little bit of editing. Well, we had to make a couple of changes to rescue Randy. He's still on the floor. He is too heavy to move. With all that being said, normally for an EMS student, especially during their rideouts, they're more so focused on patient care, establishing vital signs, maybe using some of the medications they learned about, and establishing an airway device on scene. With that being said, you probably didn't ask that many questions, or you let the lead medic take care of it. Well, what I always like to do whenever we have a 10 to 20 minute ride is, as a lead medic, I would usually be sitting right in the captain's seat, heading over to the hospital. I'll tell the EMS student, hey, now's your time to ask some questions. Why don't you go over your sample mnemonic and your OPQRST mnemonic again? One other thing, since we administer medication to our patient, it's vital that we reassess vital signs. We want to pay very close attention to our patient's blood pressure, heart rate, respiratory rate, and SpO2, while also making sure we don't forget to check a temp and blood sugar, depending on the medical scenario at hand. So if I look at the new and improved Rescue Randy, and I want to ask them my sample mnemonic, I can go first with signs and symptoms. Hey sir, how are you feeling right now? I'm feeling a lot better. I don't have a head anymore. I feel like my breathing's gotten a lot easier. Well, that's great to know, sir. Do you have any allergies to any medications? Well, as you may have already figured out, I'm allergic to bees. I'm also allergic to penicillin and sulfa drugs. Okay, that's good to know. Thank you. If I was a lead medic back there, I'd be nodding my head like, oh, good catch. I needed to ask about allergies. So you've helped out the team as well as getting more information for your report later on. Do you take any medication, sir? Well, I take my EpiPen every now and then if I have an allergic reaction. I also take amlodipine, okay, that's for blood pressure. I take Eliquis, okay, that's a blood thinner. And I take simvastatin, okay, that's a cholesterol medication. Okay, thank you for letting me know, sir. Do you have any past medical history I should know about? Any past cardiac or respiratory issues? Well, sometimes I have occasional DVTs. That's deep vein thrombosis, which may explain why he's currently on Eliquis. That's why I'm on Eliquis. Okay, well, there we go, right? Besides that, I have hypertension. Okay, sir, but have you had any heart attacks, strokes, or anything I should know about in the past? No, nothing like that. Okay, that's good to know. When's the last time you ate something? Well, I had a breakfast taco earlier today. I'm jealous. I wish I had one right now. Besides that though, do you remember what happened? Well, I was working outside. Whenever I got stung by some bees, I ran inside, and that's when I called you guys. So, we've gone over a sample mnemonic. We can consider the OPQRST mnemonic if the patient is having any pain. Sir, are you having any pain right now? No, I'm not having any pain right now. Everything seems to have calmed down, but I was really just worried about breathing. Okay, so we won't use the OPQRST mnemonic at this time, but if we did want to, we need to remember that it's onset, provocation, quality, radiation, severity, and the time that it occurred. Some other things that you can ask that are really important to gather for these kind of calls is pertinent negatives. So you can say, have you been experiencing any nausea, vomiting? No, I feel good right now. Okay, that's something good for you to put on your report. Even though that isn't something that he's experiencing, it's good to put pertinent negatives, at least whenever you're writing your patient care report, to show that you went through an extensive questioning with your patient. Whenever you're doing your write-outs, one thing that can be really concerning to students is creating a radio report for these type of scenarios. Whenever I was an EMT student, I was expected to call in a radio report to the hospital. We're going to go over one now, so that way you can get an example to do so whenever you're doing your write-outs, or if you're on a call by yourself. Medic 72 to Spawn Shoreline. Spawn Shoreline, go ahead. Medic 72, we're en route to facility code 1 with an A0 times 4 30-year-old male patient who's currently complaining of being stung by bees. The patient was presenting with hives. We gave him 1 round of epinephrine via an auto-injector at 0.3 milligrams. Currently, his baseline vitals are as follows. BP is 136 on 72. Heart rate is at 98 beats per minute. His SpO2 is at 96%. His temp is at 97.4. And his finger stick is at 108. ETA to facility in approximately 15 minutes. Copy that, Medic 72. We'll see you on arrival. Okay, so we're going to go ahead and simulate that this is the nurse and that we've dropped off our patient into their assigned room, and now we're going to work on transitioning our care. So if you're my student, while my partner is taking the stretcher out to go ahead and wipe down everything, I'd like for you to stay here and listen to my report that I'm going to give the nurse. Afterwards, we can go help out my partner, but it's really important that you listen to this because whenever you're by yourself, you'd be expected to do this whenever it comes to patient care reports. So, hello miss. Hello sir, what do you guys have today? Well, I have a 30-year-old male patient. He was outside working on the lawn whenever he started to get stung by bees. He ran inside and called 911. That was approximately 45 minutes to an hour ago. He did present with urticaria. He had some obvious shortness of breath, but he was still standing at 95% on room air whenever we found him. We went ahead and gave him an epi auto-injector administration at 0.3 milligrams IM. Since then, last known set of vital signs was BP was 132 on 74. Heart rate was at 96 beats per minute. His SpO2 was at 98%. Finger stick was at 108. Temp was at 97.4. He is allergic to bees as well as penicillin and sulfa drugs. He takes amlodipine, simvastatin, as well as Eliquis. Why does he take Eliquis? He takes Eliquis because he has a past history of DVTs. No current DVTs at this time though. Copy that, medic. Do you need me to sign your report? Yes, please. Okay. Well, thank you. Sir, I hope you feel better. Oh, thank you guys very much. Alright, let's go ahead and clean up the box. Well everyone, I hope you enjoyed this video, and I wish you the best for your EMS clinicals and write-outs. Just remember that the most important thing is that you're having fun, you're trying to be outgoing, and be the best write-out that you can possibly be. That means obtaining vital signs, trying to jump into calls, making mistakes, but understanding that that's part of the process. So if you have any questions, you can always talk to myself, one of the other instructors. We'd all be really happy to help answer any other questions you may have. But with that being said, thank you guys for watching, and I will see you on the next one. See ya. All right. Got it.